Hi everyone, it's Dr. Crad. Today I want to share an interesting case with you. A very nice lady came to see me. She had already had cataract surgery elsewhere in her first eye. This was years ago, but she was very unhappy with her vision. Understandably, she was afraid to have cataract surgery in her second eye due to the poor outcome in her first eye. But as time progressed, her second eye's cataract was getting worse and worse. She tried to put it off as much as possible, but at some point she couldn't put it off any longer. She needed to do something about it. So she presented to me needing cataract surgery in her second eye. She asked me to fix it, but of course hoped that I could avoid the mistake that occurred with her first eye's cataract surgery. If I'm completely transparent with you, whenever a patient presents with a bad previous experience with another doctor, I have mixed emotions. On the one hand, I feel, what if I make the same mistake? I'm an ophthalmologist like the other doctor. I'm human. I make mistakes like anyone else. Perhaps the first case was legitimately difficult, and perhaps I would run into the same issue. On the other hand, I feel this is an opportunity to really make this patient happy. She has anxiety about her outcome, and I know I'm going to do everything I can to exceed her expectations. In this situation, I'm sure a lot of other surgeons feel the same way. Well, in this video, I'll show you what mistake was made with the first cataract surgery, how we made sure to avoid the same problem when performing her second cataract surgery, and finally, what we did to try to fix the problem in her first eye. So here's the issue with her first eye. This patient had previous RK surgery, also known as radial keratotomy. RK surgery was a surgical procedure performed decades ago before the advent of LASIK. Cuts were made in the cornea to flatten it and reduce dependence on glasses. Cataract surgeons around the world know that when someone has had previous RK surgery, the measurements taken in preparation for the cataract surgery or refractive lens exchange can be unreliable. The cornea is often unstable, fluctuates, and the predicted lens power could be significantly off target. Aiming for plano, or a zero refraction, was the goal. But as you see, she's extremely off target. So clearly this patient had the wrong lens implant placed in her eye. So I take biometry measurements at my office in both eyes to see what lens powers are recommended. There is not a huge discrepancy between the two eye measurements. They are fairly symmetrical, in the mid-teens. Does that mean I'm about to make the same mistake as the previous doctor? Then I request records from her previous doctor's office to see what lens implant was placed. I want to see her op report, which should have the lens power on it. So I get the op report, but the lens power is not written on it. So then I look for the biometry measurements. And as you can see here, they are in the same ballpark as mine, diopters in the mid-teens. This obviously causes me greater concern because I don't want to make the same mistake again. However, there must be an explanation. So I dig deeper into her records and I find another set of biometry measurements, another set of lens measurements with a very different lens power recommendation, diopters in the upper 20s. So which lens did the previous surgeon put in? I assume the stronger lens implant was put in, as that would make sense, but I wanted to be sure I'm not missing anything. So I see the name of the surgery center on the op report and decide to call them. And they confirmed that a 27.0 diopter lens was implanted, and it should have been a much less powerful lens, around a 15.5 or 16 diopter lens. Finding the source of the problem with her first eye surgery gave me the confidence with our surgical plan for the second eye, and it gave the patient the reassurance that it wouldn't happen again. Now, as we were approaching her cataract surgery, I did suggest that we implant either the light adjustable lens or IC8 Apthera to maximize her potential vision. But the cost was prohibitive for the patient and she wanted only what her insurance would cover. That's understandable, and so we just went with a basic monofocal lens. So we performed the surgery, and as expected, it went smoothly and predictably, and no huge refractive surprise. So now she has one eye, which is pretty much on target, and her previous eye with a large refractive error. Our options are to leave it alone, exchange her lens implant, or place a second lens implant in a piggyback fashion on top of her original lens implant. So we decided the piggyback option was the safest route to give her balanced vision, given that her surgery was done years ago. And here is a video of us performing the surgery. First, we make our paracentesis and then irrigate the eye with some numbing solution. Then we inject viscoelastic to maintain the anterior chamber, followed by creating an incision, making sure we still have a gap between our incision and the RK cuts. Then injecting viscoelastic into the ciliary sulcus. Next, we're going to inject the 3-piece lens, and this is very easy because we created space in the sulcus. This is a -9 diopter Sensor AR40 lens. We calculated this by taking her manifest refraction and multiplying it by 1.2. If you were correcting a hyperopic refractive error, you would multiply it by 1.5. Now the lens is in the anterior chamber, but we're waiting for it to unfold. There we go. And next we're going to rotate it into the ciliary sulcus. I like using a Kugelin instrument at the haptic optic junction to rotate the lens in, but you can use any secondary instrument to do so. And of course you want to make sure that the IOL is centered like in any other case. After that, we're just going to remove the viscoelastic, hydrate our incisions, seal the eye, and make sure the eye pressure is appropriate. I always like to stress test the incisions to make sure they don't leak, so I just tap the eye, make sure there's no fluid egressing from the eye. And even though this is watertight, I do want to put a suture in this case. This patient is about a 4-hour drive from me, and so I just want to be extra cautious. After the patient has fully healed, I can remove the suture in the office depending on how much astigmatism they have. When the suture is of appropriate tension and it's rotated and buried, most patients will not feel it at all. Fortunately, this worked out very well. She was myopic, so we calculated the Piggyback lens implant power by multiplying the manifest refraction spherical equivalent by 1.2. We put in a -9.0 diopter lens implant and it came out perfectly. Of course, she had some astigmatism because we went with a basic monofocal lens, but at least her eyes were well balanced now and she was happy. Here I am rotating the suture to bury the knot within the cornea, and then I'm going to check the incision and eye pressure one last time. In this clip, you can see both of the patient's lens implants. The Piggyback lens is the one on the left, and the original lens implant is the one on the right. As always, thank you so much for your attention. I appreciate you watching. I'll catch you on the next one. Peace.